Hi, I'm Dr. Clair Francomano. I'm a medical geneticist at the Indiana University School of Medicine, and it's my great pleasure to be here with you to discuss hypermobile Ehlers-Danlos syndrome and the hypermobility spectrum disorders. Consider the comorbidities. Ehlers-Danlos syndromes and the hypermobility spectrum disorders are complex multidisciplinary disorders. They manifest in virtually every organ system in the human body. Dr. Heidi Collins, who is the former chair of the Medical and Scientific Board for the Ehlers-Danlos Society, has said, if you can't connect the issues, think connective tissues. And I really love this phrase because so often patients will present with complex symptoms in virtually every organ system, and physicians have a very difficult time putting all the pieces together. So it's really important to remember that if there are multiple complex issues that are seemingly unconnected, it may be because there's an underlying disorder of connective tissue. Now, the musculoskeletal involvement is primary in many patients with the Ehlers-Danlos syndromes and hypermobility spectrum disorders. These conditions are first and foremost characterized by joint laxity and/or instability. So people affected by these conditions will frequently present with subluxations and dislocations. Many patients have a tendency for tendon or ligament ruptures or tears because the connective tissue is very fragile. People present with chronic musculoskeletal pain, and they may have frequent sprains. Patients will often tell me their ankles just roll for no reason, and they sprain their ankles. So these manifestations are often what bring patients to their first medical attention. And when we're thinking about the management of the musculoskeletal symptoms, in general, the strategies involve muscle relaxation and muscle strengthening and toning. And I'm listing here just a few of the recommendations that I often make to my patients in my practice. We will stabilize unstable joints, but only on an as-needed basis. You don't want to be wearing braces 24/7, but if the braces are used when they are needed, they will not cause any kind of weakness. You won't lose function in the muscles if they are used consistently, if the muscles are used consistently. So, for example, if the ankles are prone to rolling and people are getting a lot of ankle sprains, I'll use or recommend an ankle brace for times when the person is going to be on their feet a lot or if they're going to be walking on unstable terrain. And those braces then will help to support the ankles. They'll enable the person to do that exercise or that enjoyable activity, a walk in the park or whatever, and then the braces can come off after they're doing the activity. We use physical therapy for muscle relaxation when the muscles are really tight and causing pain. So often the muscles will go into spasm because they're trying to do the work that those tendons and ligaments are meant to do, but the tendons and ligaments aren't holding the joints in place because the connective tissue is weak. So the muscles are really trying hard to hold those joints together. They go into spasm and they cause chronic musculoskeletal pain. So physical therapy for muscle relaxation can really make a big difference to alleviate some of that discomfort. And those strategies may include deep heat, ultrasound, the use of massage, electrical stimulation, or something like called far infrared laser therapy. Any of those strategies will help relax the muscles and decrease that pain from muscle spasm. There's also a technique that's called myofascial trigger point release. Often this is done by means of a technique called dry needling. Now, the myofascial trigger points happen where the muscles interdigitate with the connective tissue. So myo is for muscle and fascia is the connective tissue. And that trigger point happens where the muscle is holding on to the connective tissue, and those fibers that hold on to the connective tissue are going into spasm and causing what we call a trigger point. And the trigger points send pain through the connective tissue to distant locations in a very predictable manner. So there's a map that says if you're having pain here, the trigger point is likely to be in this other distant location. And release of that trigger point at its site will alleviate the pain, the referred pain that's happening at a distant location. So dry needling is a technique where they use acupuncture needles to go in over the trigger point and just up and down with that needle, and that will cause those muscle fibers to relax. Some practitioners use manual therapy to release the trigger points. Some use actually wet needling where they inject an anesthetic into the trigger point. There are a number of different techniques, but the main thing to know is that those myofascial trigger points exist. They cause referred pain at distant locations. It is predictable where the trigger points will be based on where the pain is, and they can be alleviated in a number of different ways. Now, if the TENS machine or electrical stimulation is helpful in the physical therapist's office, I encourage my patients to consider using one at home. These TENS units used to be very expensive. They are no longer very expensive. They've become quite affordable. And it's really a helpful tool to have in your toolkit to help alleviate musculoskeletal pain. Epsom salts are another good tool to have at home. Epsom salts are magnesium salts, and magnesium is really, really good for muscle relaxation. Excuse me. So, you can either use 2 cups of Epsom salts in a bath, or if you're just soaking your feet, you can put 1 cup of Epsom salts in a foot bath, and the skin of your feet will absorb those magnesium salts, and they will help with muscle relaxation throughout the body, even though you're only soaking your feet. Now, I spoke a little bit earlier about physical therapy for muscle relaxation, but you also need to be doing physical therapy for toning and strengthening those muscles. So we want to get them relaxed, but then we want to be improving the strength and improving the tone so the muscles will be able to hold the joints together without causing pain. And I particularly recommend considering aquatic PT because physical therapy in the water is really, really helpful for many people with joint laxity. The water helps to hold the body together. If it's a warm water pool, it's going to keep the muscles relaxed while you're doing the exercise. And you can do many things in the water that people have difficulty doing on land. So, and it need not be swimming. So you can do deep water running with a flotation belt on. You can do water walking in the shallow end of the pool. There are aquatic exercise classes that people can do. And some aquatic physical therapy programs actually have treadmills or stationary bicycles in the water that people can do exercise, those kinds of exercises inside the water. So that's something to consider also. Now, I prescribe a compounded analgesic cream that many of my patients have found to be helpful. This cream has diclofenac, which is a nonsteroidal anti-inflammatory. It has 2 muscle relaxants, cyclobenzaprine and baclofen, gabapentin, which helps with nerve pain, lidocaine, a local anesthetic, and magnesium, which, as I mentioned earlier, is really helpful for muscle relaxation. Now, this compounded cream is made up in a pre-measured pump that delivers 1 gram of cream per pump. And the recommendation is for 1 or 2 grams to be applied where the pain is happening 3 or 4 times a day. So a maximum of 8 grams a day of this cream. One of the issues that we have with this prescription now is that many insurance companies are reluctant to fill compounded products. But if it's possible for the insurance to cover it, it can be a useful adjunct in managing musculoskeletal pain. Now, muscle relaxant medications can be helpful because, as I mentioned earlier, muscle spasm is often a major cause of musculoskeletal pain for people with joint laxity. However, the muscle relaxants can go too far, and if those muscles are really holding the joints together and you relax them too much, then it will increase the instability and might make things worse. So we have to be very careful about the use of muscle relaxants. The same is true of Botox. Now, some people have had really remarkable improvement in pain from Botox, for example, for temporomandibular joint pain. Some people are successful in using Botox for muscle spasm in the muscles in the scalp region, for example, for headaches. But here again, if you use Botox in an area where the muscles are really holding things together, those muscles won't be able to do that anymore, and it can exacerbate instability. So that's something to be aware of and be careful before embarking on that. Cardiovascular manifestations include orthostatic intolerance. Many people with the hypermobile type of Ehlers-Danlos syndrome and hypermobility spectrum disorders experience difficulty when they go from lying down to sitting up or standing. They become lightheaded, dizzy, or woozy. And this is a manifestation of something we call postural orthostatic tachycardia syndrome or neurally mediated hypotension. So with postural orthostatic tachycardia syndrome, the heart is racing. We have something we call an inappropriate tachycardia or inappropriate high heart rate. With neurally mediated hypotension, the blood pressure drops. And some people have both the tachycardia and the low blood pressure, and that is makes it doubly difficult to tolerate those changes going from lying down to sitting up or standing. Mitral valve prolapse is another manifestation that we sometimes see in people with the Ehlers-Danlos syndromes or hypermobility spectrum disorders. And in a small number of patients, we may see aortic root dilatation. Now, particularly in the hypermobile type of Ehlers-Danlos syndrome, this aortic root dilatation is usually very mild and does not progress to dangerous levels. Now, some of the strategies that we use in treating the cardiovascular manifestations are really targeted at increasing the circulating blood volume. And this is particularly for those people who are experiencing orthostatic intolerance. We want to try to increase the circulating blood volume to ameliorate the symptom of wooziness or dizziness with changes in posture. So first thing is we want to ensure adequate salt and water intake. And the recommendation for the amount of water to drink daily is calculated by taking the body weight in pounds and divide that by 2. So that gives us the amount of water in ounces that a person should be drinking daily. Now, in addition to supplementing with water, we want to make sure that there are adequate amounts of electrolytes on board. And the reason for this is that the kidneys are very sensitive to the ratio of salt and water. And if we put a lot more water into the body without increasing the number of electrolytes that we have, the kidneys will say we have too much water on board and just eliminate it in the urine. So we need the electrolytes to help the kidneys hold on to that water and increase the amount of circulating blood volume that we have in our blood vessels. Electrolytes there are so many different options for supplementing electrolytes. There are a lot of options out there in the retail world these days. I've been recommending salt stick capsules, which are manufactured by a company called Vitasium. Those might be the easiest because you just take 1 or 2 pills once or twice a day, depending on your needs, and you're done with it. Liquid IV and New One are 2, and again, these are 2 of just very many options that are out there. But the liquid IV is a powder that you put into the water and drink it as an electrolyte drink. And New One is like a little fizzy, a tablet that you would put into a bottle of water and make an electrolyte drink. So any of those are good options. Now, compression stockings or compression garments are useful for people with hypermobile Ehlers-Danlos syndrome or the hypermobility spectrum disorders for a couple of different reasons. The compression stockings help return the blood from the legs and the feet back to the center and the core of the body. People who have lax connective tissue will dilate their veins, and just due to gravity, they can put up to 1/3 of their blood volume in their feet and their legs. And that really diminishes the amount of oxygen carrying capacity that's available to the heart and the lungs and the head. And therefore, the heart is working overtime. That's why the tachycardia starts going. It just starts pumping faster and faster to try to get more oxygen to the lungs and to the head. And if we can return the blood that's sitting there in the feet and the legs back up to the heart, we can improve the symptom of tachycardia. We also know, and this is another manifestation that we see in many patients with hypermobility, proprioception can be diminished in these patients, and the compression garments can help us by helping kind of inform us where the limbs and the joints are in space. So the compression stockings and compression garments serve 2 different roles. One is for the cardiovascular treatment and also to help with proprioception. Usually when somebody is diagnosed with any hereditary disorder of connective tissue, an echocardiogram is done to assess the mitral valve and the aortic root. If we see a really dilated aortic root, that would send us down a different diagnostic pathway in thinking about alternative hereditary disorders of connective tissue that may be manifest as what we call aortopathies. But typically, if a person has a diagnosis of the hypermobile type of EDS or hypermobility spectrum disorder, the aortic root may be mildly dilated but will not be greatly so. Now, sometimes aggressive hydration and salt are not sufficient to really take care of the symptoms of orthostatic intolerance. And so in some patients, we may need medications such as Florinef or Midodrine to improve those symptoms of POTS or neurally mediated hypotension. There's a class of drug called beta blockers that can be used to help treat the tachycardia. One of the problems with the beta blockers is that they often will decrease the blood pressure while they're slowing the heart rate. And so for this reason, there's a new medication, relatively new on the market, called ivabradine, that is increasingly being used off-label for the treatment of POTS symptoms. The brand name for ivabradine is Corlinor, and this medication slows the tachycardia, slows the heart rate, but does not drop the blood pressure. And many patients with really debilitating POTS have found that ivabradine is really, really helpful for them to regain a lot of functionality in their lives. Okay, now we come to neurologic involvement in the hypermobility spectrum disorders and the Ehlers-Danlos syndromes. One issue that is really prominent for many, many people is that of headaches. Often people will complain of headaches, and there are many different causes of headaches for people with joint laxity and joint instability. So just a few of the causes of headaches that we recognize are headaches that are caused by muscle spasm that may be related to instability in the craniocervical junction, that place where the head joins up with the neck, or in the upper cervical spine where C1 connects with C2. People get headaches because of temporomandibular joint dysfunction and muscle spasm related to TMJ dysfunction. There can also be stress-related headaches, and there can be headaches that are due to changes in the cerebrospinal fluid pressure. So either increased pressure for the CSF or decreased pressure for the CSF. The decreased pressure would be typically related to a problem with a CSF leak, which may happen along the spinal region, or you can get a CSF leak in the head. So there are many, many causes of headaches, and you have to really delve into what the cause of the headache is to know what the appropriate treatment will be for that particular person. Now, cervical medullary syndrome is a phenomenon that I'm going to discuss a little bit later. It's a constellation of symptoms that is related to instability at the craniocervical junction, instability at C1-2, or a Chiari malformation. So I'll talk, those will be the next couple of slides. I'll be talking about cervical medullary syndrome. Other neurologic issues involved in these conditions include neuropathic pain, because the nerves may be compressed at any number of joints if the joints are unstable. There's the phenomenon called occult tethered cord, where the base of the spinal cord is being compressed by a band of connective tissue that's wrapped around it and causes compression of the nerves that go to the perineum and to the bowel, the bladder, and the legs. And so patients with a tethered cord will present with urinary symptoms. They may have bowel symptoms, including constipation. Typically, they describe a feeling of heaviness in their legs that is worse when they're walking upstairs or walking up a hill. And often patients with a tethered cord will say that they, as youngsters, that they were toe walkers. They didn't put their heels on the ground when they were learning to walk. One other thing that we see with the occult tethered cord is that patients have a preference for sitting with their legs tucked up underneath them. They may sit in a crisscross position when they're seated. They might, when they're even riding in a car, they might put their feet up on the dashboard, and they often have a preference for sleeping in a curled up position, just trying to minimize the stretching of their spinal cord when they're lying down. So those historical pieces of information can be helpful in guiding us to thinking about whether or not the cord may be tethered. There is also a phenomenon of cerebral venous insufficiency. So we know that the veins may not be returning blood properly coming from the legs, and typically we think of that as being a problem with gravity. But how do we explain that cerebral venous insufficiency? Because the veins from the head are coming, the blood is traveling downward rather than up in the veins. So this is something that we don't really understand completely anatomically, but it seems that there are some veins in the head that do become narrowed, and they prevent adequate return of the venous blood to the heart, and that can build up the pressure in the head because there's a relationship between the blood volume and the cerebrospinal fluid pressure in the head. So that's something to look for in cases of headache where we're not able to find another explanation. We see a lot of degenerative disc disease in patients with Ehlers-Danlos syndromes and hypermobility spectrum disorders. The disc disease may start very early, even in the teenage years, and that is because the discs in between the spinal vertebrae are they're made of connective tissue, and so they're prone to this degenerative process. There may be spinal instability. The relationship between the vertebrae in the spine those are joints, just like other joints in the body, and so the tendons and ligaments that hold those in place are also sometimes falling down on the job, and they can cause excess movement in between the vertebrae. And finally, this issue of small fiber neuropathy is something that is gaining a lot of attention lately. Typically, patients will report sensation of pins and needles or kind of a creepy crawly feeling on their skin, and sometimes diminished sensation. And so to think about a small fiber neuropathy is important if people are reporting those kinds of symptoms. And the diagnosis of small fiber neuropathy can be made by a tissue biopsy, skin biopsy, and the pathologist stain for those small nerves, the tiny fibers in the skin, and they just count the number of those small fiber nerves. And if there is a diminished number of nerves in the skin sample, that is representative of a small fiber neuropathy. And the importance of making that diagnosis is that there are things we can do to treat it, and some people are using intravenous immunoglobulin for treatment of small fiber neuropathy. Now, I promised I'd come back to the cervical medullary syndrome. These are the symptoms of the cervical medullary syndrome. They include headache, suboccipital pain, which is pain right at the base of the skull where the head joins up with the neck, or neck pain. And typically patients have bulbar symptoms. This means symptoms related to compression of the medulla, with altered vision, double vision, nystagmus, which is the eyeballs kind of moving in a back and forth direction. They may have decreased hearing, dizziness, problems with balance or vertigo, choking, difficulty with speech, difficulty with swallowing, difficulty with the autonomic nervous system or POTS. They may have fainting or feel like they're just we call fainting syncope or pre-syncope, or they may have disordered sleep architecture and sleep apnea. And when we examine patients with cervical medullary syndrome, we see symptoms of a myelopathy or problems with the muscles, including weakness and clumsiness. There may be some spasticity, altered sensation, paresthesias, which means just those numbness and tingling kind of things, or dysesthesia, where there's a sensation of, sometimes patients tell us that it feels like there's water on their skin, even though it's not wet. There may be changes in gait and urinary urgency and frequency. And this definition of the cervical medullary syndrome was published as a consensus statement from the Chiari-Syringo-Mylia Foundation Multidisciplinary Colloquium in 2013. When we suspect cervical medullary syndrome, if a person is experiencing significant impairment of function and there is evidence of cord compression on the neurologic exam, the usual process for evaluating the patient is to perform what we call an upright MRI of the cervical spine in neutral, flexion, and extension. These upright MRI machines allow the patient to sit in the machine and they're looking straight ahead, and then the images will be taken in neutral with the chin flexed towards the chest and looking up at the ceiling. If we do not demonstrate instability on the MRI in neutral, flexion, and extension, a CT scan to look at C12 in rotation can be done. And so in that case, the patient's going to be turning their head to the left and to the right, and we're looking to see whether there's instability between the top two vertebrae in the cervical spine, between C1 and C2. So by those two studies should enable us to see whether there's instability at the craniocervical junction through the MRI or in the upper cervical spine through the CT scan. Now, gastrointestinal manifestations are another big category that often bring patients to attention. They may have irritable bowel syndrome, which may be either diarrhea dominant or constipation dominant. Many patients come in complaining of abdominal pain, gas, bloating, and diarrhea, which may be related to a food intolerance specifically. Many patients report esophageal reflux. Less commonly, we hear about difficulty with control of the feces or fecal incontinence. Some people will have some leaking of stool. Hernias are a frequent complication, and we may see something called sphincter of Oddi dysfunction. The sphincter of Oddi is involved in the flow of the digestive juices between the pancreas and the liver. So because there is a wide range of different symptoms in the gastrointestinal tract, there is a wide differential diagnosis. There are many possible explanations for the symptoms that people experience in the GI tract. And these include gastrointestinal dysmotility, or problems with movement of the GI tract, which may affect any piece of the GI tract, starting with the esophagus and going all the way down to the colon and the rectum. Problems with the autonomic nervous system may control or may underlie gastrointestinal dysmotility, but may also be involved in mast cell activation. We know that When the autonomic nervous system is not working properly, the mast cells are more likely to react inappropriately. Small bowel overgrowth may be a cause of some GI symptoms, celiac disease, and food intolerance and allergies. So, similar to what I was saying about the cause of headaches, we need to understand the cause of the GI symptoms to make sure that we're embarking on the appropriate treatment strategy. So, some general strategies for managing GI symptoms. If we're able to demonstrate slow gastrointestinal motility, there are a wide range of medications that we call prokinetic or pro-movement medications that help prompt additional movement in the GI tract. If mast cell activation disorder or mast cell activation syndrome is suspected, a trial of mast cell treatment is reasonable. And we also look for food sensitivities and allergies and eliminate allergens. And often this can make a huge difference in the discomfort that people experience after they eat if they're not taking in any of these foods that are causing the allergic type reactions. Okay, moving down the body now to the urologic features. Often patients will report urinary urgency and urinary frequency or burning on urination. Some patients will describe difficulty initiating the urinary stream or difficulty emptying the bladder completely. Some will have either dribbling or frank incontinence of the urine. And some patients report they have frequent urinary tract infections, or they feel like they always have a urinary tract infection, but they're cultured, the urine is cultured, it's sent off for looking to see if there are any bacteria in there, and no bacteria show up, and then we call this a culture negative result. So, in terms of evaluating the genitourinary symptoms, here again there's a wide differential diagnosis that may explain some of these symptoms. So the autonomic nervous system plays a very important role in regulating the management of the GU tract, the genitourinary tract. So dysautonomia may cause some of these urinary symptoms. If people have mast cell activation, the mast cell activation in the bladder manifests as a diagnosis we call interstitial cystitis, or inflammation of the bladder wall. There may be anatomic differences in the GU tract. For example, there may be reflux between the bladder and the ureters. And as I mentioned earlier, if there is a tethered cord, the nerves that go to the bladder may be pinched, and that may cause something called a neurogenic bladder, a bladder that the nerves going to the bladder are impinged somehow, and therefore the bladder is not working properly because it's not getting the right instructions from the spinal cord. So treatment for all of these symptoms will depend on the underlying cause. And if somebody is having urologic symptoms that are really interfering with their quality of life, a urology consultation is warranted to help establish a diagnosis and a treatment plan. Now, in the field of hematology and allergy, we also have a wide range of symptoms with which patients may present. There may be a history of hives, rashes, flushing, itching, frequent infections, severe allergies. Some people say they just really react very, very badly to mosquito bites, for example, or any kind of insect bites. They may have autoimmune disorders or a history of blood clots. So if we have a high suspicion for mast cell activation, we can test for mast cell activation. There are a number of tests that we can do. We look for the release of specific inflammatory molecules that are released by the mast cells. But these tests are very specific, so if they're positive, it's really helpful to us. But they're not highly sensitive, which means that a negative test is not really that informative. So we can look for tryptase. The test for tryptase is used often to look for evidence of mast cell activation. There's another molecule called N-methylhistamine that we can look for. But often these tests are negative even in people who are really having symptoms that are very highly suggestive of mast cell. So my strategy has been a kind of a pragmatic one, and if my suspicion is very high for mast cell activation, I usually recommend a trial of treatment, which I call my mast cell 101. So we use antihistamines, blocking H1 and H2 receptors. Histamine interacts with the cells in the body through two different receptors, H1 and H2. And the class of drugs that are the H1 receptors are things like Zyrtec, Allegra, Claritin, Benadryl. All of these block the effect of histamine at the H1 receptor. And the H2 blocker that's used most often in the US these days is Pepcid. So usually I recommend Zyrtec 10 milligrams once a day and the Pepcid 20 milligrams twice a day as my antihistamine regimen. Then we use a mast cell stabilizer. The mast cell stabilizer keeps those mast cells from releasing all their inflammatory molecules. And it's important to remember the mast cells have hundreds of different inflammatory molecules inside of them. And histamine is only one of those. It's one of the most common ones. It's the one that causes most of the skin and many of the GI symptoms. But if we stabilize the mast cells, then we don't have to try to run around blocking all those other inflammatory molecules that the mast cells might be releasing. So chromolan sodium and ketotifen are usually, we need to get a prescription for those. They're obtainable by prescription. Quercetin is a supplement that can be obtained over the counter. So the use of a mast cell stabilizer and the antihistamines. And then the third thing is that we avoid the higher histamine foods. So there's a website called histamine-intolerance.ch. It's a Swiss website that has a very extensive list of foods and ranks each of those foods from 0 to 3. So the 0s and 1s have minimal histamine effect, and the 2s and 3s progressively more so. And usually what I do is I recommend for the patients to just limit themselves to foods that are 0s or 1s for 3 weeks. And then starting on day 22, to add one food each day that's either labeled a 2 or a 3, and to track their symptoms. Does it make the pain worse? Does it make rash worse, hives, abdominal pain, bloating, etc.? So if a person who has a suspected mast cell activation does the antihistamine, the mast cell stabilizers, avoiding the higher histamine foods, they do that for a month and they're not seeing any improvement whatsoever, then they need an allergist or to seek help from a specialist who can help somehow. I call this my mast cell 101. Then they need a higher level course to try to improve their symptoms. Now, finally, living with a complex medical condition is very difficult. We know this. It's challenging physically, it's challenging mentally, it's challenging emotionally. So coping is really, really an important aspect of the multidisciplinary care for people living with hypermobile Ehlers-Danlos syndrome, any of the Ehlers-Danlos syndromes really, or the hypermobility spectrum disorders. And some strategies that people may find helpful is the use of cognitive behavioral therapy. Mindfulness-based stress reduction is a strategy for to just use the mind to help with stress management. Biofeedback or neural feedback can be very helpful. I can't emphasize enough the importance of patient support groups, finding people who are living with the same kind of symptoms and knowing that a patient is not alone in this struggle can be really, really helpful. And finally, exercise. I can't overestimate the importance of exercise for patients with joint hypermobility. It really is a key element in the management and thriving for people with EDS and HSD. And my usual recommendation for exercise is 30 to 40 minutes of low impact exercise most days of the week, so 4 or 5 days of the week. And I can't tell you how many patients have told me that if they exercise regularly, they feel so much better. And as soon as they stop, it really becomes more problematic. And I recognize that there are many patients who are not able to get to this level of exercise, and the goal is to gradually increase. So even people who are bedbound can start just by doing very, very minor movements of their muscles using isotonic measurements, isometric measurements, isometric exercises, and slowly increasing the number of repetitions of things they can do. And it may take months to get to a place where you can even walk 10 minutes, but shooting for that goal is really an important strategy for lifelong improvement in health. So that concludes my presentation. Thank you so much for your attention.